So Todd, thank you so much for inviting me to give this talk. I've had a chance to look at a few of the talks today that have been part of the teach-in. I have to say how incredibly impressed I've been. But yet again, it reinforces to me this idea that we need more cross-pollination across the folks that study aphasia, but from different angles. And I hope that at some point we can come up with some kind of a conference where we are more likely to meet, that is the folks that are interested in aphasia, but maybe are not using exactly the same approaches, the same methodology to study it. So I will also apologize here for my very generic title. When it came time for me to actually send in my title for the advertising the program, I really hadn't decided what I was going to talk about, and I thought about several different things, but what I'm going to go for here is I'm going to start by talking about impairment-based therapy for aphasia, talking there about long-term outcomes, predictors of outcome, and then comparing two therapy approaches to see which one is better and for whom is it better. If I have time, there are a couple of other topics that I'm going to touch on, but certainly not to the same extent that I'm going to be talking about the impairment-based therapy for aphasia, and that is in defense of naming as an outcome measure in aphasia treatment studies, and then hopefully something that I'm pretty passionate about, and that is why don't we have more funded aphasia treatment studies? And when I say that, I'm specifically talking about here in the United States. I don't know what the status is so much in other countries. I see a lot of activity now in Australia, and I feel like in many ways they have really taken the lead in our field in aphasia treatment. And I wish that we were able to get up the same kind of thrust here in the United States. So I'm going to talk a little bit about that at the end. I hope I get to it. So impairment-based therapy, there's considerable evidence suggests that impairment-based therapy is effective for improving aphasia. One of my favorite trials and favorite studies, period, is this trial by Breitenstein et al., where they compared impairment-based aphasia therapy to improve speech production and quality of life to a control group. This was published in Lancet back in 2017, and I think that in pretty much every lecture that I give, I mention this paper, and I still think that it's highly important. Other evidence that we can point to that impairment-based therapy is worthwhile is this meta-analysis by Marion Brady et al. That was published in 2016. I'm not so much going to focus on the background, but rather mostly focus on some of the work that we have been doing here at the University of South Carolina and our affiliated institution that are involved in the Center for the Study of Aphasia Recovery, or CSTAR. And the trial itself that I'm going to focus on is called POLAR, or Predicting Outcome of Language Recovery in Aphasia. I'm going to specifically address what are the long-term effects of therapy, what therapy works best and for whom, and what factors are related to therapy success. Before I go any further, I want to thank these spectacular people for providing me with many of the visuals that are going to be included in this talk. These are folks who are here at the Center for the Study of Aphasia Recovery. First, Dr. Alexandra Basilakos, Dr. Laura-Leigh Philip Johnson, and Sigfús Kristinsson. Alex is a research assistant professor with us, Laura-Leigh is a postdoc, and Sigfús is a graduate student. So much of the credit for the visuals that I provide today goes to them. I also want to say before I get to the end that all of the work that I'm talking about here is to the credit of a large group of people, including an army of speech-language pathologists who do an outstanding job in collecting our data. So I'm going to start by talking about what baseline factors are related to long-term outcome. That is, if you're a speech-language pathologist and you get the next person on your caseload, is there something specific about that person, either in your testing or perhaps in their chart, that you can look to determine how likely is it that this person is going to respond? I'm also going to talk about, does impairment-based language therapy lead to sustained improvement in language processing? And there I'm going to be talking about 1 to 3 years follow-up in our current treatment study. So I'm just going to delve right into POLAR. The inclusion criteria for POLAR is that participants have to have incurred a left hemisphere ischemic or hemorrhagic stroke. They're all at least 1 year post-stroke. The reason why we do that is because we want participants who are fairly stable, although we know that aphasia in most individuals is not that stable even when they're years beyond stroke. Our participants have been between the ages of 21 and 80 and are all native speakers of English. And some of the exclusion criteria, what we exclude are people with extremely severe aphasia. So somebody who has a score on the spontaneous speech rating scale on the Western Aphasia Battery of 0 to 1, or severely impaired auditory comprehension of 0 to 1, also on the Western Aphasia Battery. We also exclude bilateral stroke, and we do that mainly because a big part of our study is wanting to understand what is brain plasticity that spurs recovery from aphasia. But if we were only doing this for treatment purposes and not interested in the neuroimaging at all, I don't think that we would have included the bilateral stroke necessarily as an exclusion factor. So here's the study protocol. Everybody that comes into the study at intake undergoes very thorough baseline testing that takes about 2 to 3 days and involves various tests of language and cognition and live participation. They also undergo MRI scanning, which I'm not going to be talking about today. And then after that, they're randomized to either get therapy that focuses primarily on phonological processing, or therapy that focuses primarily on semantic processing. So there are 2 arms. That therapy goes on for 3 weeks, that phase. They get post-treatment testing, they rest for a couple of weeks, and then they get pre-treatment testing for the second phase. Those who, let's say, started with a semantic approach, then once they have gone through this 4-week waiting period here, they go through the phonological based treatment, and vice versa for the other arms. Start with phonological, wait, and then get the semantic approach. We do testing immediately after treatment, so the week after the second phase. We do 1 month testing and then a 6-month testing. We had a supplement that we got from the National Institute on Aging to look at long-term outcome in participants, and that was Alexandra Basilakos. And that's the data that I'm going to share with you on 1 to 3 year follow-up of aphasia therapy. Here's the flow chart for enrollment. We've, at this time, when we froze the data for a couple of papers that we have in review right now, we had assessed for eligibility 103 individuals. We actually have quite a bit more now, but for our purposes today, this is the sample that I'm going to be talking about. We randomized 92 into either getting first the semantic treatment or the phonological treatment first. And then, of course, in either one of those arms, they would go into this, in the second treatment phase, they would get the other treatment approach. So these folks start with semantic treatment and then get the phonological treatment, and vice versa for the other arm. The number of participants whose data I'm going to be discussing today in the initial study is 63. So these are folks that have completed everything through the 6-month follow-up. Here are some of the participant characteristics. Age at baseline, the mean age was 60 with a really wide range from 29 to 76. More than half of the participants were men. Time post-stroke varied from 1 year to 20 years. The average time after stroke was 4.5 years. The Western Aphasia Battery aphasia quotient, which is a measure of overall aphasia severity, also a really wide range from 14.5, which is certainly very severe aphasia, to somebody who has very mild aphasia here with 93.1. Also wide ranges of stroke severity abilities with regards to naming on the Philadelphia naming test, which is one of our outcome measures, and also with regards to the number of words produced during discourse tasks, which is our other outcome measure. So everybody who's included in Polar undergoes 6 weeks of aphasia therapy, 3 weeks of the phonologically focused therapy. There are 3 different approaches that we use in that phonologically focused therapy. Everyone goes through these 3 different approaches in every one of their sessions. However, we certainly tailor each one of the approaches to that person's ability level. So if somebody is having a hard time, we try to make it easier. If somebody's having an easier time, we make the treatment more difficult. So the 3 approaches that we focus on here in the phonological treatment is this phonological component analysis, then a phonological production task, and then finally an in-house task that also focuses on phonological judgment. The 3 weeks of the semantically focused therapy, again, 3 different approaches. Semantic feature analysis, I think that most people are very much familiar with that. A modified PACE task, which also I think most of us who are SLPs know. And then VNest, we include also in the semantic approach. The study is unblinded with regards to the crossover design. And for everybody, they get 1 hour of therapy, 5 days a week for a total of 30 sessions. And all the treatment is administered by ASHA certified speech language pathologists. If anybody's interested in the assessment and treatment fidelity in the study, we go to great lengths to make sure that all of our SLPs are using exactly the same procedures, that they are consistent, and that the outcome raters are consistent and reliable. We described that in Spell et al., published this year in the Journal of American Speech Language Pathology. So the outcome measures, we focus on confrontation naming, the correct naming on the Philadelphia naming test to account for day-to-day variability. In performance, the PNT is given 2 consecutive days at baseline, and the performance is averaged across days. For those people who have very discrepant performance on those 2 different tasks at baseline, at each one of the follow-up times, we also do the test twice. If the performance is fairly similar on the 2 tests at baseline, we only do the PNT once at each one of the follow-up points. We also assess discourse production, and there we, for this study, we are only looking at the number of correct words produced per minute on 3 different discourse tasks. We use the aphasia bank protocol. We collect a narrative sample, an expositional sample, and a procedural sample, and then we average across those 3 samples to come up with our correct words per minute produced during discourse. And we use Chat and Clan, which I'm pretty sure that many of you are familiar with, to code and get our data for discourse. A little bit more about the outcome measures. I'm going to be talking about mainly the treatment of the outcome of the naming test, so the Philadelphia naming test, and also the correct words per minute. We also combined those 2 measures. We simply calculated z-scores for both outcome measures, added them together, and came up with a composite score, which we call a speech production outcome score, or SPOTS for short. And then for outcome prediction, initially what I'm going to talk to you about are 5 factors that we're interested in. Can we use those 5 factors to predict how well a person is likely to respond to a given therapy? Those are age, education, aphasia severity, score on the matrix reasoning test on the ways, which we call basically our cognitive assessment, and then overall severity of apraxia of speech rated on the ASRS, or the apraxia of speech rating scale, by Strand and colleagues. So I'm going to talk about the results here from the from Polar, starting with the initial sample, so the 63 participants. So predicting long-term outcome from spots, and then which therapy works better. When we talk about which therapy works better, what we found, and we looked at this a lot, is that the variability and the stability of the naming measures is a lot better than what we find with the discourse measures. And therefore, when I'm talking about comparing the phonological therapy to the semantic therapy, I'm going to focus on the naming part only. But for predicting long-term outcome, I'm going to focus on spots. I will also talk about long-term outcome with regards to just the naming score and the discourse score separately. So predicting improvements in naming and discourse at 6 months post-treatment. So that's the last outcome assessment, other than what we've then added later with this 1 to 3 year outcome assessment. But in the original plan, we wanted to look at changes in or improvement at 6 months post-therapy. So increase on the Philadelphia naming test in correct naming was statistically significant. Now I will emphasize here, this is not a randomized controlled trial comparing treatment to no treatment. This is just simply comparing pre-post, where people naming more at the end compared to the beginning. And same thing with the discourse measures with regards to total words produced per minute, and that was also statistically significant improvement. Now, the main purpose here was to look at, can we use the baseline factors to predict who responds and who doesn't? So I'm going to start here with the stepwise regression model predicting the outcome for spots. Remember that that's the combined outcome measures for discourse and naming. I can certainly see some pros and cons to doing that, but that's what I'm going to show you right now. What we found was that the best predictor of outcome was age. And that was a statistically significant model. It explained about 16% of the variance, or the R squared was 0.16. A second model, which further improved the prediction, we accounted for approximately a quarter of the total variance with an R squared of 0.24. That prediction model included age, but also in addition to that, overall apraxia of speech severity. So two models, the more comprehensive one, predicting about quarter of the variance with regards to who improves at 6 months compared to baseline, including then apraxia of speech severity and overall age. What we get here in this correlation table is a little bit more of the same. The outcome measure that we're talking about here is spots, which I highlight here in the last column.
Julius.
And the predictors here are at baseline. So, yes, sir.
I'm gonna grab. Great, I'll keep admitting folks and we'll go from there.
I'll just keep cruising. Let me start my timer here again. All right, so where was I? Let me see. Yep. So for the outcome measure spots, which remember was a combination of the naming and the discourse measure, the factors that were associated at baseline. So do we know something about a given individual based on these factors about how well they would respond? And the factors that were most important were age, which has the highest correlation, which is negative. And then Western aphasia battery, AQ, so overall aphasia severity, apraxia of speech severity, but the two factors that did not contribute significantly to the model was the amount of education and this cognitive score right here. That did not contribute literally anything. So overall severity, age, and apraxia of speech severity were predictors of outcome. So I want to add a little bit here about the outcome measure. One of the things that we did was that we took the model the general linear model at baseline using those factors for 63 participants. We built the model on 62 participants and looked at if we plug in the next person's baseline factor, can we predict how well that person is gonna respond to therapy? I think that this is absolutely crucial to aphasia therapy studies, because if we eventually want to translate what we're doing into clinical practice, we need speech language pathologists to have actual data to use. So when they get their next participant or patient or client or whatever, they can say, well, here's a therapy that is probably going to work for you as opposed to a different therapy that is not going to work well. So what you have here on the x-axis are the actual spots scores. So these are the change scores on the x-axis. What you have on the y-axis, however, are the predicted scores. So 63 times we built the model with 62 participants, and we tried to predict the 63rd participant. That is, we're essentially trying to say, can I do out of sample prediction? And what we find is that the correlation between the actual scores and the predicted scores was, the correlation was 0.44, which was highly significant, which suggests that our model is pretty good. So that simply knowing how old a person is, how well they did on the Western Aphasia Battery, and how severe their apraxia of speech is, we can predict fairly well what is going to be their long-term outcome with our treatment approach. So an interim discussion here before I move on to comparing the two treatment approaches. Impairment-based aphasia therapy improves language processing at 6 months, at least how we measured it, looking at correct naming and overall speech output during discourse. That is, can people simply talk more at the end compared to at the beginning? Long-term success is related to participant characteristics. Better outcome was associated with less severe aphasia, younger age, and less severe apraxia of speech. We also did out of sample prediction, and that was to see whether we can infer the response of the next participant based on the participants that we've seen so far, which I think is, again, a crucial part of any aphasia treatment study. And you can imagine that the ability to do out of sample prediction, that is, say something about the next person that we're seeing based on what we saw before, is going to be strongly related to the sample size of your study. You can only imagine trying to do a study with, I don't know, let's say 8 participants. Your model in predicting the 9th person is going to be pretty poor. So that is very much related to generalization. That is, can we say something about the next person on my caseload based on the data that I've already collected? So now moving to comparing the semantic versus the phonological therapy. Remember, this was a crossover design. You either got the semantic treatment first and then phonological, or you got the vice versa order. So phonological first and the semantic second. And we did assessment before and after. And for both phases, participants waited a month between the end of one phase to the start of the next treatment phase. So here's the table that describes the results from the crossover design. So if we start here with a group that got the phonological treatment first, that is this line right here. The improvement in naming, we actually looked at proportional improvement in outcome. So looking at how much room do you have to improve and how much of that room did you fill up with your actual improvement. So looking at proportion there. The participants who got the phonological treatment first did not see a statistically significant improvement in their outcome, which was the correct naming on the PMT. However, the treatment that they got second did lead to statistically significant improvement, and that was, the p-value there was 0.007. So this is the semantic treatment for the participants that started with a phonological approach. Now, for the other group that had the reverse order, Those are participants, first when they came in, they got the semantic treatment, waited a month, and then got the phonological treatment. So here's the result of the semantic treatment. They improved about 8% of their total room for improvement, and that was statistically significant. However, when they got the phonological treatment, that did not improve their abilities at all. Now, if we compared within the groups, which approach was better, the first treatment or the second treatment, there was no difference for the group that got phonological treatment first. However, for the group that got semantic treatment first, it really mattered. The semantic treatment for those individuals was statistically better than the phonological treatment. So here's a slide that I want to dwell on just a little bit, because I think it's very important in demonstrating the data that were yielded in our study. What we have done here is that on the x-axis, we have plotted the individual participants. So this is 63 participants from the start here to the end. And what we plotted was change in naming following the phonological treatment, which is blue. And what you can see is that, for example, this individual got way worse. And many of the individuals with a phonological treatment actually did worse at the end compared to the beginning. And then what you see is the changes following the semantic treatment in the red bars. Now, what you will find out is that there are some people that actually got, well, one individual that maybe a couple of individuals, this individual got worse following both of the therapies. As opposed to this person all the way here on the right. So this person, regardless of what treatment approach they were getting, responded well to both. There are some that tend to respond to both therapy approaches here on the far right, but most of the participants either responded only to one therapy or the other, or did not respond at all. That would be those folks here in the middle. These are actually participants in here who did not respond at all. So if you just add together all the red bars and all the blue bars, what you will find is that the semantic treatment overall yielded far better outcome than the phonological treatment for these 63 participants. If I remember correctly, the improvement with the semantic treatment compared to the phonological was almost, I'd like to say 3 times. I should know this off the top of my head, but if I remember this correctly, it was either twice or 3 times better with the semantic treatment compared to the phonological treatment. But what really matters here also is that there is great variability in response to treatment depending on what therapy approach is being applied for each individual. Now you might say, well, maybe it's just in this study and this doesn't reflect what else we see in our world of aphasia treatments. But I would bet that most treatment studies that you look at, you will get maybe something that is not that different than here, that there are some people that respond a lot, some people that don't respond at all, and some individuals actually who get a little bit worse. But overall, at least in our sample, the semantic treatment yielded far better results overall than the phonological treatment. That does not mean that that was the case for each individual, because what is important here is not the group response, but rather the response of the individual, because ultimately what we want to be able to say is, for the next person that we see in therapy, we want to be able to say not just, we think you're likely to respond to therapy, but we would like to say you're more likely to respond to therapy A compared to therapy B. So the individual predictors for the semantic treatment, which was different than the predictors for phonological treatment, the overall regression model accounted for more than half of the variance. So what that means that model, if we know how people scored or what their individual characteristics were at baseline, we can account for half of the variance with regards to how well they responded to the semantic treatment. It was a lot of factors, and I know that I didn't talk about all these tests that we did at baseline, so I'm gonna go through them here. So maybe all the different factors are not so important, but the best predictor was just the spontaneous speech score on the Western Aphasia Battery. That accounted for over a quarter of the total variance for predicting outcome. Other factors that were important was just the total number of verbs produced during discourse tasks. Other factors that were important were things like auditory short-term memory, non-word repetition, and people's rhyming scores. How well can they rhyme on Nadine Martin's TALSA test? So several predictors that were contributed individually to understand who responds to the semantic treatment. But overall, the model was highly efficient, explaining over half of all the variance with regards to improvement. That was not the case for the phonological treatment, perhaps because the response itself for the whole group wasn't that strong. The only statistically significant regression model only accounted for 5% of the variance, which is really poor. And that had to do with sex, in that males were more likely to respond to the phonological treatment than females. I would say that that's not much to write home about. I think that has a lot more to do with the variability that we had in the data rather than this being a strong predictor of outcome. So comparing across the approaches, what we found was that looking at the fluency score on the Western aphasia battery, that folks who had non-fluent aphasia, so a rating of 4 or below on the Western aphasia battery fluency score, they responded significantly better to the phonological treatment than the fluent participants, and that was statistically significant. And you might say, well, there wasn't a statistically significant improvement on the phonological task, but yet, keep in mind, there's a lot of variability in response. And in this case, if you have non-fluent aphasia, if you had to pick an approach and you were interested in, for example, improving your overall speech output, what you should be focusing on is more phonologically focused treatment. However, the fluent participants responded much better to the semantic treatment compared to the non-fluent participants. And again, that was statistically significant. We did also look at aphasia type. We did not have very good representation of the number of people with Wernicke's aphasia, transcortical, motor, and global. The main differences that we saw with regards to which treatment approach is better was the semantic treatment was better for the folks with anomic aphasia and the folks with conduction aphasia. For the folks that had Broca's aphasia, which was a large proportion of our sample, it didn't matter. They seemed to respond to both treatment types. I'm going to spend one slide here. I'm going to look at the time here really quick, make sure that I'm not going over. Long-term outcome. So this was that study that we added on looking at change from baseline to 1 to 3 years post-stroke. So we assessed folks at several different times after completion of the study, which remember was a 6 months follow-up. And what we found was that changes on the Western aphasia battery, which is something that we did at baseline, and again at the end, this is not looking at naming, this is looking at your overall aphasia severity. I'm going to show you, I'm going to explain this graph here a little bit. It's a little bit confusing. What you have on the y-axis here is the baseline aphasia quotient. So this is the severity of the person at baseline, and that is what you see in the gray bars. So that's baseline AQ. However, on the y-axis on the right, you had the change in aphasia quotient. So we've color-coded the bars here for each one of the individuals. So each one of these bars represents an individual. Here's one individual, second, third, fourth, fifth, etc. A person that has a red bar declined by more than 5 points on the Western aphasia battery AQ. So that is a person that saw a decline 1 or more years following their initial entry into the study. Folks who have a blue bar did not change either plus or minus by more than 5 points. And then finally, those individuals that you see here with the green bars, those improved by more than 5 points. So you have 5 decliners, if we define it like that. And then we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 people that in the long run experienced improvement on the Western aphasia battery that amounted to at least 5 points on in the AQ. So overall, what we're seeing here is for almost half of the participants, they are seeing changes. More than half of those participants that experience changes saw an improvement. For less than half of those who saw changes, it was an actual decline. And we're looking at why specifically that decline occurs, and that's research that is being spearheaded by Alexandra Basilakos, who's already started publishing on that. So I just wanted to share that with you. These are the long-term outcomes of our aphasia treatment study. So comparing treatment approaches, overall treatment focused on semantic processing yields superior results compared to treatment focused on phonological processing. However, and it's important, however, different kinds of therapy work better for different individuals. If you have fluent aphasia, you are more likely to respond to the therapy, the semantic therapy. If you had non-fluent aphasia, you were more likely to respond to the phonological therapy. And you might say, well, maybe it's just these two therapy approaches, but I would bet you that if you took any two therapy approaches, unless they were almost exactly the same, and did a similar study, your results would not be that much different. I think that the most important thing here is that the same therapy approach, and I think we implicitly know this, is not going to work for everybody. But unless you do a study like this, you won't know what those factors are that predict how well you're going to respond to one therapy as opposed to another. We certainly know that there is, looking at the predictors of response to treatment, there's a complex relationship between the personalized predictors and therapy success. So the take-home message for me here, at least, is that personalized rehabilitation matters. And you might say, well, you're looking at huge groups, you're not looking at the individuals. That's not the case. What I'm looking at here is that we can take the group data so we can know something about the next person, so that we can look at that person. What is it about you that makes you more likely to respond to one therapy approach as opposed to another? Or maybe you're not likely to respond to either one, and therefore we need to look for something else. But in my mind, as a clinician, which I worked for a long time as an SLP, these are the kinds of data that I would like to have, so that I'll know for the next participant that I get tomorrow morning when I go to work, from this and many other studies that are like this, that I can use those data to better inform what I'm going to do for that person to maximize their recovery and the efficiency of the time that I'm going to be spending with them. So let me just look at the time here real quick. So I'm almost out of time. I really like this topic here on naming.
How long do you think you need, Julius?
Huh?
How long do you think you need to hit the naming?
Well, there's another one after that I'd rather hit, so I'll skip it.
Okay.
Hold on. A lot of bold claims here, but.
It's the quick tour.
I
Hopefully
know.
everybody's keeping up.
So here's another topic that I would like to talk about, and it's very different than I was talking about at the beginning, but the longer that I do this, and when I say this, I mean study aphasia and trying to do something about recovery from aphasia, the less patient I become about the progress that we're making. And there are many different reasons. I mean, it's a tough problem. There's no doubt about that. But Naina in her report suggested that there were 2 million people in North America that have aphasia. This is a huge problem that needs a lot of resources. And I think that one of the ways that we can improve the lives of people with aphasia is by doing more research, and specifically treatment research. So I went, I looked yesterday on the NIH reporter. So for those of you who are not in the States, the National Institutes of Health is the main funder of research by far in the United States. And I wanted to see how much funding is being now doled out for aphasia treatment studies. And what I found looking at their database, it's probably less than 20 studies that are devoted to treatment of stroke aphasia. And to me, that is an untenable situation. So as of last year, I know that for a fact there was not a single aphasia treatment study in the clinical trial portfolio of the National Institute on Deafness and Communication Disorders. That is another statistic that is not acceptable. So, and I see no reason over the years that the 20 plus years that I've been doing this, that funding rates for aphasia treatment studies, that they've changed in the past few decades. So what's the problem? Is it the case that we're just not applying? We're stuck in the desert and nobody is applying for grants to fund studies of the treatment for aphasia. Or perhaps we're in the forest, there's a lot of beautiful work happening, but for some reason it's not getting funded. Now, there are probably many different reasons why this is the case, but I'm going to talk about one of them, which I think is crucial, and that is grant review. They're getting applications that want to focus on treatment of aphasia. I think that those of us who are reviewing those grants, and I've certainly been one of them, and I hope that some of you who are now watching are grant reviewers and have been grant reviewers and will review grants in the future, we need to focus a lot of our effort on supporting new investigators. By that I mean, when you're reviewing a grant, I'm not saying necessarily be kind, but be sure that you support the field that you're in. If you go to a grant review panel at the NIH, you will see that there are folks in certain fields that really always support each other. And I think that that is something that we need to do as folks who study aphasia, and maybe not just in the grant reviewing, but also in reviewing our own papers. I'm not saying let lax research slip by, but always focus more on the forest than the individual trees. I see far too many grant reviews, and maybe I've been guilty of this myself. There was nothing but trees, no forest. And in the end, trying to revise a grant like that is a complete nightmare because you have no idea what the overall problem is. We need to focus primarily on empirical data. I see in our field over the years, I realize that there are many things that we believe as being truth, and I would almost call those dogma. But once you start looking, some of those things that we think are true about aphasia have very little data to support them. So whenever you're reviewing grants, make sure that what you are basing your review on is empirical data. Again, don't make strong statements about the weaknesses of a grant proposal if your argument is based on a study with very small sample sizes. I understand there's a place for studies with small sample sizes, primarily as pilot data, but, and I know that I'm running out of time, but if you want to look at any kind of rehabilitation or medicine studies that make a difference and should make a difference, those are the studies that are the largest studies, and there's a reason why we want amply powered studies for clinical trials for treatment of whatever ails our body, heart disease, cancer, whatever. We would never use a drug unless we were absolutely in dire straits for heart disease that was based on a treatment study in 8 people. We need to support not just the young investigators, we need to support others in the field. So whenever you're reviewing grants of other folks who are want to do a treatment study, again, don't let lax research go by, but make sure that whatever you are contributing is something that is based on a sound footing and scientific footing. And avoid the fallacy of, if we don't know everything, therefore we know nothing. I see reviews that people say, well, they haven't figured out this and this about the language system or that about the neuroscience. Well, are we going to wait another 20 years before people figure that out so we can start the next treatment study? In my mind, that is absolutely not a tenable position. And lastly, I want to talk about a rule that I've used as a reviewer, not just for grants, but for manuscripts. I call it the public forum rule. So whatever you write in your review, make sure that you're not shielding yourself, or I think about it, I'm not shielding myself behind anonymity. That is that they will never know who it is. Therefore, I feel comfortable putting this down in my review. If you don't think that you would get up in public forum and state this criticism and defend it for other people, it probably doesn't belong in the grant review. So I could talk about that forever, but I'm gonna stop right here. Let me see how I'm on time. I think I pretty much nailed it, maybe 30 seconds over. Sorry, Todd.